She says, trying to get the hair out my eyes.
Okay, we've started recording, so.
Okay.
Hi there, welcome. I'm Michelle Lyons, and for the past couple of years, I've been delighted to be collaborating with Jenny Burrell on putting together Woman on Fire. We have some fabulous speakers lined up for 2018, and I'm delighted to say that Jilly Bond is going to be one of them. Jilly has been a friend and a colleague for a long time on social media, it feels like, but we just met in real life at the British Pelvic Floor Society meeting in Cardiff in January this year. So Jilly is going to be talking about her specialist subject. I sound a bit like Magnus Masterson now, but bladder pain syndrome. So Jilly, if you could just introduce yourself, tell us a little bit about you, your work, and what led to your interest in bladder pain syndrome.
Hello, and thanks for the opportunity to talk to you. It's lovely to talk to you, Michelle. My name is Jilly Bond. I'm a clinical specialist pelvic health physio. I run the pelvic health service at a local private hospital in South Wales, and I have my own clinic room that I also have my own service, and I run educational courses for physios to help them to treat bladder pain syndrome more effectively and have fun. My courses are hopefully lots of fun.
Fun is good. Fun is good. And fun is not normally what you maybe would associate with bladder pain syndrome. I think it's a confusing diagnosis for both patient and clinician, and certainly it's an area that there's a lot of misinformation about as well, because it's a condition that we used to call interstitial cystitis, and now we call bladder pain syndrome, which I think is a bit more appropriate because really it's neither interstitial nor is it cystitis. So maybe you could just talk a little bit about the name change for the syndrome.
Yeah, well, it was originally called IC just because it had that element that people thought it had this chronic infection that had delved into the tissues of the urethra or the bladder. But as our understanding over the last couple of years has developed, we now know that bladder pain syndrome or bladder pain can exist without any actual bladder cause, in the absence of a pathology, in the absence of any infection. And so we've moved away from that diagnosis of it having to be related to a urine infection. And so it didn't seem very supportive to kind of still call it interstitial cystitis, because it's nothing to do with the interstitium of the bladder, nor is it a cystitis. It's much more to do with the whole system, and we're talking brain downwards rather than just the bladder. So we've got a bit of a confusing thing still going on at the moment, Michelle, because the Americans are calling it PBS and the Europeans are calling it BPS. But we all kind of agree that it's a syndrome and it's around the bladder and it involves pain. So from a British point of view, we call it bladder pain syndrome now.
Right. And I think, it's great to see it being looked at, because I think for a long time, women who did have bladder pain, but maybe didn't have the characteristic Hunner's ulcers, were almost discounted. It's not really IC, there's nothing really wrong with you because we can't see it, there mustn't be anything there. So I think it's good to see that there is, more understanding of bladder pain syndrome now coming to the fore in the research. Certainly, at the International Pelvic Pain Society last year, there was a lot of talk about bladder pain syndrome. And I think the multidisciplinary approach to it is really the way forward. Good connection with your urologist about this?
Yeah, I still find that the urologists are, some of them are leading the way, and a lot of them are still in that place where if they haven't got a glomerulation or a Hunner's ulcer on cystoscopy, they're kind of going, well, this patient, I don't know, they have dysfunctional voiding, they have a pelvic floor disorder, what can we do about them? But that's where the role of the physio comes in kind of educating our clinical colleagues about the physio scope of practice within the whole of dysfunction, because dysfunction in the bladder never comes on its own. It all comes with bowel issues and pelvic floor issues. Absolutely. Depression and anxiety. We know that one of the biggest significant risk factors for developing BPS is other functional disorders, things like fibromyalgia, IBS, what else can I think of? Anxiety, depression. And we're really good as physios at kind of having the time to look at that as a whole. And quite often when I've seen a patient, I've spent 90 minutes with them going through absolutely everything. I've written a letter back to their consultant, and the consultant comes and finds me and says, I didn't realise, I had no idea that all of this was going on. Of course they've got bladder pain syndrome. And that's how we build links and bridges, but certainly working with our colleagues to kind of understand how physio can really make a difference and can completely change the lives of people with BPS.
Absolutely. And so what typically would you see as, I mean, every patient obviously is individual, but, typical, what would a treatment plan for a patient with bladder pain syndrome? And, primarily we're talking about women. Men can get it too. But, just talk us through maybe a typical treatment planning session with you.
Okay, so I would look at the whole system. So we always make sure that we're looking at obviously the bladder symptoms, how often they're avoiding, how much they're drinking, what pain is associated with that, but also what sensations are associated with that. Because quite often when we're getting visceral hyperalgesia, we're getting normal symptoms and normal sensations being reinterpreted by the brain as other things. And pain. We do the same with the bowel, a normal physio assessment, so a full bowel screen on emptying, loading, comfort, movement, frequency. But I also look at, pelvic floor is only a small section, but it's a very important section. But I also look at kind of the brain, the amount of stress they're under, nutrition, their sleep, their understanding and education and appreciation of bladder pain, all the things that they've read on Wikipedia. And then the pelvic floor forms one section of it. From a physio point of view, we're very good at taking the whole and suggesting to patients, right, you need to do all of these things at once. So kind of 5 key areas being brain, bladder, bowel, pelvic floor, vulva, because we need to be thinking about that vulval pain. Quite often they'll have vulvodynia associated, and sometimes it's, I'm thinking of a patient I've got at the moment who has provoked vulvodynia and provoked a horrible urgency that she's just fully wetting herself when the vulvodynia is spiked. So we have to look at all of those and those 5 key areas, and you've got to address all of them. But all the research, the most recent research, we have Peters, we have Engela, we have lots of different people telling us that if we don't look at the whole system in a multifactorial way, we're not going to be able to change this. And certainly the nicest piece of research I have in my armory for my consultants is a piece that showed that if the pelvic floor was not resolved in its hypertonicity, in its pain, in its function, then symptoms don't change in the bladder. And that's great, because urologists kind of go, what? Why would that happen? But actually, when you show them and you look at the neural reflexes that go between the pelvic floor and the bladder, and from a visceral sensory point of view, we can make a really big difference to their bladder symptoms if we're kind of calming down the whole of the pelvic floor and the visceral symptoms as well.
So, Jilly, before we go any further, I can tell you now, as soon as the physios start watching this, they're going to say, what was that reference that Jilly said? What was it? So,
I've got a blog, and I'll put all of the references up on the blog from that.
Fantastic. And they can find that blog at jillybondphysiotherapy.com?
jillybond.com/blogs and blogs.
Fantastic. Great. Where do you see the role of exercise in all of this? Because, we'll have a lot of fit pros and different allied health professionals at Women on Fire. And I think everyone's going to be keen to understand their role in helping women manage this condition.
It's hugely important from down from kind of a hormone and from a system point of view. If we have patients producing serotonin and moving, not only are we getting the physical reduction in their pain response, but we're also getting the emotional level of threat level coming down. So when we talk about the threat response quite a lot in my course, and how cortisol and adrenaline will drive that central sensitization of the viscera, if we reduce that by letting people moving normally and enjoying it, which is the key, then their whole level of hypersensitivity improves. So for a fit pro is a key, and I am desperately seeking people to work with me all the time. I've got a fantastic patient who's done really well and is doing lots of outdoor swimming and lots of other stuff, and we're trying to find a triathlon trainer to work with who will understand the challenges. Now, exercise isn't something to be avoided. A lot of patients say, well, if my pelvic floor is tight and I have difficulty and I have to release it and you're releasing it and it feels better when it's released, what's going to happen when I do exercise? But I just say to them, look, like with stretching your hamstrings or stretching your quads when you've been for a run, you're going to stretch your pelvic floor, or you're going to think about ways in which we can release it, and you're just going to spend time to reduce the arousal of your system after you've exercised. The exercise is more important. So,
well, and as well as that, we still have to live in the world, so being able to do things like squats and lunges in a pelvic floor friendly fashion Because just because you've got bladder pain doesn't mean you can't also have, a prolapse or back pain or something else like that going on. So
Absolutely.
I think, having good fit pros and different allied healthcare professionals that you can work with, I think is really, really vital. I think the integrative healthcare approach is the medicine of the future. Yeah. So where do you think nutrition fits into all of this?
Oh, it's huge. There are quite a few different IC diets floating around. IC being, and I've been working with a dietitian for a while, and she's brilliant. She came on my course last time we did it in Cardiff, and presented. But there are some really key things that people can pull out of their diet, and there are things that they can add to their diet to support it. And from a nourishment and nutrition point of view, getting the basic level of nourishment and exercise with that is really important. There are certain triggers. It is different for everyone, so not everyone responds to tomatoes. And going through, I know they all try and stop eating tomatoes, but it doesn't work for everyone. But going through an elimination diet and actually working with a process and saying, right, I'm taking all of this out, now I'm putting this back in and see, is really important. And we have lots of colleagues that can do that with us. So it's hugely important to support it, but also getting the right stuff in the bladder. If we've got kind of localized neurogenic inflammation, we don't want to have things that are going to feed the inflammation, like high levels of sugar.
Yeah.
If we've got an irritable bladder lining, we don't want to be having fizzy. We particularly don't want caffeine, but more from a central point of view rather than from a bladder point of view. So there's a huge role for nutrition as well. And our dietetics colleagues are really pushing that recently. I've had a lot of work from the South Wales group helping us with that.
I think, it's like a lot of the pelvic pain diagnoses, it's getting what Jenny will often call getting the big rocks right, eating well, eating food that agrees with you, that, that you're getting good sleep, that you're managing stress, that you're moving in a healthy, supportive fashion. And really creating that environment will set you up for success in terms of not so much curing bladder pain syndrome, but managing it and living well with it, and just taking charge of your life again.
It can be significant changes because it's all a cascade, isn't it? So, when someone's not eating right, they're going to be loaded through their rectum. Then passing stool is going to be harder, which is going to be painful, which is going to drive bladder pain. So, and if they're not sleeping, the hormones that are emitted are completely different. From a chemical point of view, the bladder's heightened. So much happens. But as soon as you educate a patient and you just have that conversation, it doesn't need to be a physio. It can be a fit pro saying, are you sleeping? Are you eating properly? And this is why, because it will affect your pain.
Absolutely.
They come back into you and they say, my pain's really bad. I had one this week actually who came in and said, my pain's really bad. And I've gone, oh God, okay. What can we do? What have we done different this week? What's happening? Oh, no, it's fine. I just haven't slept for 3 days with the baby. And I go, okay, I know it'll get better when I've slept. Great.
So immediately that starts bringing down the catastrophizing, the spiraling, because there's a definite cause and effect there. She knows she hasn't slept. She knows she's a bit stressed. And so her pain is up. But she also knows that when she gets control back over those again, that her pain is going to come back under control.
It's about having that whole management plan. And a lot of my patients, most of them by the end of it, have got a really comfortable management plan that you have to put a lot of work in it to begin with and really get to grips with the whole process. But then so that lady, she hasn't, because she's been tired and fractious, hadn't had the time to go through her exercises, her stretches, pelvic floor work, and and that's the way life is.
And that's why. But so a big part, it sounds like, of what you do is actually education.
Yeah, huge.
It's, from a pain science point of view, and the whole Butler Moseley paradigm. But I think just teaching people how to start taking charge of their own health again and really empowering them to live well. It's a big part, I think, of what we as women's health physios certainly are striving to do. And just taking people out of that passive recipient model of care where we're coming in and fixing them, giving them a toolbox so that they can manage their lives. Yeah. But I think the big thing, isn't it, with bladder pain syndrome, is that everybody thinks that they're the only one with this. That there's nobody else out there with this problem, because I think there is a lack of awareness. And so I think it's really important that we have these conversations that, pain isn't normal, and that there are healthcare professionals like you out there who can, really spearhead that multidisciplinary approach to take charge of bladder health again.
Oh, absolutely. And Bladder Health UK, the charity, are doing really well in promoting a a range of MDT members at regular courses and events throughout the years for patients. But yeah, it kind of works two ways, doesn't it? Because we know there's a huge increased risk of depression, of anxiety, of, you can't get away from the toilet if you're having a flare. So get stuck in their houses, and then they spiral, they catastrophize, lots of bad things happen, they get out of kilter with everything. And they end up in a situation where they feel like no one knows what they're going through. But then conversely, from a general population point of view, it's not a condition that's understood. As much as prolapses aren't sexy, they're kind of understood. I mean,
that's an understatement.
You kind of think everything's going to fall out, but there is an awareness of it. But with yes, there kind of isn't, that it's a real condition, and they're not just needing the toilet all the time, which is,
and not just in your head.
Yeah,
which a lot of women are still told, unfortunately, as well.
Yeah, so many. I have the patient that got me into this, I call Hannah, and Hannah wasn't her name, but she came to me and said that she'd had a failed series of antibiotics and had 4 or 5 years of urologists and anaesthetists and lots of other people and gynecologists, and come out with I just have to put up with it diagnosis. There's nothing wrong with you. Well, clearly there was, because she was telling me all of these symptoms. And actually, from an empowerment point of view as well, I am absolutely with you on that. The reason that I did my master's research into using a wand was that I was in a position at that point in the health service where I could not empower my patients, and I had to, because I was able to see them every 6 or 7 weeks if I was lucky. And all of the research shows that you need to see people for about 15 to 20 minutes, that's it, for 6 weeks in a row, and then follow them up for another 6 weeks. And they have a significant difference in their ability and their symptom management and their pain. Yeah. So research that I looked at was, how can we empower women with knowledge and with techniques to be able to do the physio treatment that under our guidance, they're able to manage it. So we're not replacing physios, but certainly, hopefully what it's done is given people a little bit more data to go to their bosses and say, well, you know what, we can't follow you up for a month, but what you're going to do is I'm going to teach you how to use this one, then you're going to release your, and you're going to get some release from your flares. Now, it's not for everyone. Not everyone wants to do self-touch. Not everyone wants to use stuff internally, but at least it gives them that empowerment. And the best example I've got of this was a GP who came to see me, and she's fab. And she'd had it for a long time, about 8 or 9 years, and just put up with it, because even though she was aware of the research, she just didn't really know what to do about it. We set out, she had a great management plan. She hadn't drunk alcohol in a long time, and I got because of her symptoms, and I got a postcard from France, and she said, sat on a vineyard, drinking my wine, woke up at 3 o'clock in the morning with excruciating pain, would have usually been 3 weeks of tramadol and morphine and lots of stuff, and off work, managed to relax my pelvic floor, meditate, do some stretches, and was asleep by 5 o'clock. I know.
That's a win.
Yeah, exactly. And that's a successful management story. So
now, just before people think you're going all Harry Potter, this is what Jilly means by a wand. It's no, we're not magic wands. No magic wands, I'm afraid. They can be quite magical if they're used properly on the right patient, but just to clarify for people who may not be familiar with wands and their uses.
Yes, they're just replacing my finger.
Exactly. What would your main tip be, Jilly, if a woman comes in and you're suspicious of bladder pain syndrome with somebody who's coming in to see you as a fit pro, as a physio? What are some of the red flags that would tip you off that you might want to start thinking that it's bladder pain syndrome?
History of pain for more than 6 months in the bladder region. It's better when they can have a wee. It gets worse if they have to hold and stop having a wee. And it doesn't have to have anything to do with an infection, but maybe they're getting some pain with intercourse, or their pelvic floor region is sore as well. Certainly, if you are a professional and you're assessing pelvic floor, if it's painful on palpation, then that's a positive diagnosis. Bladder pain syndrome is a diagnosis of exclusion, which means they have to go through, on average, 7 to 12 years of testing to have like 14 laparotomies and lots of stuff going on, to be told that they've got it, because nothing else is, that they haven't found anything else they've got. Picking up someone that has got pain related to their toilet habits from the bladder end, it's probably in the spectrum. And now the spectrum is completely different, as we mentioned kind of Hunner's ulcer and glomerular earlier. And we can go from really bladders that are very inflamed, very small, very stenotic, very unhappy, unable to empty fully, all the way through to just a little bit of urgency with pain and maybe some everyone's different. The serious significant ones, hopefully from a fit pro or from a physio point of view, we're not picking them up too often because they're being managed better in the early stages. It isn't a linear progression, but that kind of 3C, as we'd call it, the really horrible bladders, are being picked up better before they get there. And you don't necessarily have to have the Hunner's ulcers or the glomerulations to be down the worst end. You can have Hunner's ulcers and be bleeding from the bladder, but actually have very little symptoms. So I would just say, be aware if it's pain related to that voiding cycle, getting rid of the fluid in the bladder, then you've got to be thinking bladder pain syndrome. Reach out. I'm around. Michelle, that can come and talk to you. There's lots of, from a women's health point of view, lots of people around treating it. So come and have a chat with us if you're unsure.
For sure. Okay, well, I think that's fantastic. I think we really just want to shine a light on bladder pain syndrome and the work that you're doing. We're very excited to have you speaking at Woman on Fire. So you'll be doing a full session on bladder pain syndrome with clinical pearls and tips for treatment. And again, just really hopefully empowering women, as we've said, just to live well. And I think the best way we can do that is through education. So we'll look forward to seeing you in Brighton next April. And come and join the conversation at Woman on Fire. We had an amazing time last year. It's going to be even bigger and better this year. We have a range of different topics and speakers. So you can go to BurrellEducation.com, Woman on Fire 2018. So Jilly, thanks for joining us, and we will see you in April, if not before.
Yep, see you soon. Bye.
Okay, bye.